Welcome, everybody. Thank you for the introduction, Clint. And for those of you who haven't met Clint Hendrickser, he's officially our new head of division. We're very excited for what this leadership will bring us in emergency medicine. And equally so, thank you to the department for giving me the opportunity to present on work currently underway as a national initiative for emergency medicine. Which is looking at renewing our curriculum for the specialist training program in emergency medicine. I thought it would be appropriate to, give me 1 second. Sorry, just lost my screen. What's happened? Need to change that. Sorry, 1 second. There we go. There we go. Okay, sorry about that. So I thought as a first step, what I'd like to do, especially for those who are new to emergency medicine, was to give you a little bit of the background and then go through a description of the curriculum transformation process. And thereafter, give you an idea of the few of the outputs from the work undertaken so far in terms of our values and our competency domains, which are still very much under construct. And then an overview of our assessment blueprint, and then the cyclical work that is ongoing here from. Now, for those of you who know something about emergency medicine, it might appear to be the new specialty or the new kid on the block. But in actual work, in actuality, the work has been undergoing since 1980s. When the DBEC was offered by the College of Family Practitioners, that is the Diploma in Emergency Care. In 1990, we had the Trauma Society of South Africa being established, and soon after followed the Emergency Medicine Society of South Africa. In 2001, the Division of Emergency Medicine at the University of Cape Town was established, and our first program was the Master of Philosophy in Emergency Medicine. That same year, EMSA became an affiliate of the organization known as the International Federation of Emergency Medicine, or IFEM. In 2003 was a big milestone for emergency medicine when we became recognized as a specialty by the HPCSA. And in 2004, we were registered within the College of Medicine of South Africa. The DBEC as well was transferred to the College of Emergency Medicine, and the first MS Specialist Training Program in Emergency Medicine started at the University of Cape Town. In that same year, EMSA became a full IFEM member. By the year 2012, we had 5 emergency medicine specialist training programs within the universities of Cape Town, Stellenbosch, UKZN, Witwatersrand, and KwaZulu-Natal. And we're also offered the higher diploma in emergency medicine from that year on, otherwise known as the HDIP in emergency medicine, offered by the College of Emergency Medicine. In 2018 and up until 2020, the diploma, which was in high demand at that point in time, was reviewed and was capped at 80 candidates per semester. And I'd like to think that after the current work we're undertaking, that a new milestone will be noted here from 2022. That is the curriculum working group to renew the FCAM curriculum, or the Fellowship of College of Emergency Medicine. When many people think about emergency medicine, we think about this one face that has been associated with emergency medicine in South Africa. Prof. Lee Wallace, for those of you who don't know, oversaw quite a bit of the work that was done to spread emergency medicine, both nationally in Africa and internationally. He has now handed over the baton, and for the University of Cape Town, we're under the leadership of Clint Hendrickse, and on the Stellenbosch side, Heike Geduld. Speaking of Heike, if you love pictures as much as I do, I've stolen this one from her. And this was the very first class of registrars for emergency medicine in South Africa, some of whom you will recognize. Heike Geduld herself, who heads up the Stellenbosch Division of Emergency Medicine, Kirsty Cohen at New Somerset Hospital. Won't talk about Adrian because he defaulted to anesthetics. Sherrod Garage at UKZN, Carstensen Yalga in private practice. We've got Pauline Lowe, who at the back is in Paarl Hospital Emergency Centre, and Rick Kropman in C15 for this year. You must recognize our very own baby-faced Peter Hodkinson right at the back. And then Melanie Stander, who is at the higher echelons of medical clinic management. And so since 2007, then, we've begun churning out high quality specialists, both locally and in Africa, and became recognized as the leaders in emergency medicine, I'd like to think. And so our program currently looks very much like we have practiced for the past 2 decades. Like most specialties, it's a 4-year program. At 36 months, a registrar is suitable, could potentially write the FChem Part 2, which is the final exams. We have 2 points of assessment. One is the primaries, which historically had to be completed within 18 months of entry into the program. And then the second part of the summative assessment, which is the final exam right at the very end of the training. Theoretically, a registrar would come in and build on foundational knowledge in years 1 and 2, and then more acquisition of applied knowledge in years 3 and 4. And that knowledge would grow in depth as they approached expert or medical expert. At the same time, in parallel, they would do short courses. And of course, the MEd needed to be completed before they sit the exam. In the context of UCT and Stellenbosch, the MEd exam must be marked and passed before a registrar can apply to write the Part 2 exam. The Level 1 ultrasound accreditation is necessary as an entry requirement into the exam. And so as the years have passed, we found that, the way our registrars looked who were coming into the program have changed. We have a huge demand of applicants for registrar posts twice a year. We have anything between 10 and 20 applicants for each sitting or for each interview. And our registrars come in with many years of experience in emergency centres, most of whom would have already have had the Part 1 exams, as well as already being ultrasound accredited, if not ultrasound instructors who have already published in terms of research. And so that, as well as the context of the environment that and the communities that we serve, have changed over time. And so it's that realization, as well as literature such as the Lancet, Health Professionals for a New Century, Transforming Education to Strengthen Health Systems in the Independent World. It's articles such as this that make us sit back and reflect on how we're training our graduates, how we're educating, and whether we're actually graduating individuals or specialists that are fit for purpose. And so what we've done, a few of us initially considered whether we are actually being responsive to the health system. We have a curriculum, or have had a curriculum, that was adapted from IFM and presumed to be suitable for LMIC, but was it really? And so began this process of inquiry. And in parallel was a mandate from the College of Medicine to renew our curriculum, but with a focus on including work-based assessments and the consideration of EPAs, which is a concept I'll go into a little bit later. And so because of that process of inquiry, coupled by the mandate from the CMSA, but spearheaded by the College of Emergency Medicine and our president, Saad Lari, thanks Saad, We came together as 6 universities, Pretoria, KwaZulu-Natal, Witwatersrand, WSU, Stellenbosch, as well as UCT, and formed what we now refer to as the National Curriculum Change Working Group. And what we accepted was that we'll have 2 processes running in parallel to bring about a renewal to our curriculum. And one would be a draft by June 2023. But what we all accepted was, because this was such an enormous amount of work that needed to go into actually making this a meaningful curriculum that represents who we truly are, that there will be in parallel a dynamic process which we refer to as the living curriculum. And this will invite cyclical processes of curriculum inquiry and renewal. And so we're probably looking at about 5 years, if not more, for the curriculum as we would like it to go from construct to implementation. And so as a working group does, we, sort of understand what is the design of this process and how do we go about it. And there's so many different frameworks that we could use. Kearns is just one of them, but what they all have in common was to understand what the needs are. And so the very first process was a general needs assessment followed by a targeted needs assessment before we were able to derive the goals for the program and the objectives, never mind considering necessarily right now the educational strategies and following from them implementation and evaluation. For those who appreciate the theory of change model, which is familiar to UCT, as it's been included in the undergraduate curriculum transformation process, what I found useful was to position these in such a framework to help us to identify the processes, the outputs, the outcomes, and the impact that will have. And that process of a situational analysis involved putting together a widely represented curriculum working group, which we have done. And so began a process of a project plan and task delegation. We then went through a general needs analysis. We understood the CMSA requirements, what was required to us from the HPCSA, and we also looked at reviewing curricula from the Global North and LMIC. We then were able to identify what the core requirements and qualifications were, and all of this was with a view of actually ensuring that we have a curriculum that qualifies the requirement by authorizing bodies. What was very important for us, though, was the targeted needs analysis, and we were very intentional about making certain that we included all stakeholders. That included the registrars, our faculty. We included semi-structured interviews with other stakeholders from the Department of Health we'll go into now. And what we want to do and will still need to do very much so is engage with the community. And the idea behind this is to identify contextually relevant needs of all stakeholders. And we're hoping as an impact at the end is to ensure that we have a curriculum that is transformed, that is student-centered, where we're socially accountable, and that we are inclusive of primary healthcare concepts. Historically, when we look at curricula, we always assumed, or well, I did anyway, that our core stakeholders ought to be, or partners ought to be, the universities, the authorizing bodies such as the HPCSA, and the colleges of medicine of South Africa, and more specifically, emergency medicine. But we realized that we cannot make a meaningful or create a meaningful curriculum without including the essential stakeholders, our partners in the Department of Health, where our extended communities of practice lie, such as our nurses, our different specialties, different professions, but also our community. Are we actually being responsive to their needs is a question that we must still ask ourselves. We need to consider the burden of disease and whether what we educate for is in parallel or is responsive to that burden. But most importantly, we needed to be inclusive of the student voice. In addition to this, we understood that it was important to delineate competencies. But considering the iceberg model, it is actually easy to identify perhaps the knowledge and skills that one needs to have as an emerging specialist or a graduate. However, what's harder to change is what lies beneath. What are those core values? What are the attributes of identity? What drives us in terms of our need or our influence? What drives our function? Who are we as a specialty of emergency medicine? And so began a needs analysis and process of inquiry. And I thought I'd add these here, as these are quite interesting. For some of us in universities, we engage with different methods. Most of us use focus group discussions. Others gave our partners the opportunity to sketch what the values are and what they perceive to be an emergency physician. And interesting, we came across attributes such as manager, a good listener, somebody who's efficient, resourceful, flexible, a good clinician who's level-headed and all-rounder, and a superhero, in fact. But also, we recognize that values such as compassion, kindness, and a good listener were equally important. Issues of identity came up as well quite strongly. Are we generalists? Are we resuscitationists? Who are we exactly? In the context in which we practice, we see this as as rather disrupting or some areas of conflict. Are we actually generalists? Are we on the spectrum? Or are we indeed resuscitationists with additional responsibilities or attributes? A little bit more here, a lion for those of you who can't make that one out. A manager, resilience, somebody who's knowledgeable, and a team player. An all-round impact player, somebody who's calm under pressure, and a master at multitasking, but also a good teacher, and one who's able to manage skills. So really sounding like everything and anything in a sense. And so we were tasked, and I have to say this was probably the most productive of exercises. We were collaborating for 6 months. The 6 representatives from the 6 universities, that is, online, which was very difficult. And I think the most valuable exercise in all of this time was a workshop, which was a week long. We all met in person, and we went through a process of data analysis, and we were able to get quite a bit of work done. And once again, I just want to highlight that this is just one phase of the data analysis process, and we're probably going to go to multiple iterations and have many more conversations with different partners before the final construct of our curriculum. But through this process, we were able to identify core values. As you can tell, the resuscitationist was there. We needed to be resource and context-specific practice, that we were agile, broad thinking. Teaching and learning featured strongly, but also the need for us to identify as a specialty. What does that identity mean for us? We appreciated that we needed to take on a high level of responsibility and independence, and that we needed to be socially aware or possess situational awareness. But what came through quite strongly, which wasn't included or perhaps not considered, because we had a very biomedical focused curriculum so far, was the sense of community focus, a sense of team-based practice, interprofessional, transprofessional, collaborative practice, the sense of self and anti-fragility, the need to develop self and the need to be empathic, trust in faculty, trust in each other, and the ability to learn, to be assessed and to receive feedback. And very importantly, the concept of transformation and decoloniality. We took many lessons from the Fees Must Fall movement, and we had very intentional discussions around what does decoloniality mean. And this is just a chart taken from one of such discussions with our registrars. And this was a session where registrars from all over the country were invited to participate. And what was quite interesting and quite revealing was their understanding. And what they understood was that the process of decoloniality means to nurture and to value Afrocentric values and ideologies. they were very open about the fear that being Afrocentric meant poor quality or not being globally relevant, but also that it was important to be inclusive and that the work that we do and who we are and how we practice actually has societal impact. And that decoloniality was both a culture and reflected on our ways of being, and that we needed to very clearly deconstruct those values that we had or those ideologies, and perhaps the reason behind why we were so fearful that becoming more Afrocentric meant a lesser quality. And so we need to really address that ingrained culture. We need to ensure that our Indigenous voices are heard and that we are person-centered. And so this was the beginning of many conversations to come. And I think that in itself, in having those very open and honest conversations, is part of the process of decoloniality and transforming our curriculum. And so through this process, we merged our baobab tree, which we are very proud of. It is under construct and therefore not your very svelte looking, icon as yet. But for those of you who are familiar with the CanMEDS framework, this is similar to that. So this consists of competency domains encircled by our values. And what we have come up with is that the South African emergency physician is a socially accountable medical expert who is rooted in community, as evidenced by team-based and context-specific practice. She's one who leads and manages, is a critical thinker, a professional, a good communicator, both a teacher and a learner, who prioritizes well-being and self-development. And so this was the easy part in a sense, is identifying what our broad competency domains are. But then came across the question, well, how do we actually assess for these? What we knew was that we needed to make sure that we had sufficient data points to make a decision about our registrars. We wanted to value the process of learning as assessment for learning as opposed to assessment for simply progression or final summative decisions. We wanted every assessment or experience to count, and we wanted to make sure that there was a rigorous process in which the final decision about the registrar was made. And so we realized in time that we were actually referring to what is called a programmatic assessment. For those of you who are interested, Van der Vleuten writes about this extensively. And there are core features or principles on which a programmatic assessment is built. And that speaks to what our needs are as a working group, that the methods that we choose should depend on the educational justification for using that method, that our decision-making on learner progress is proportional related to the stake, and that our assessment information is triangulated across data points towards an appropriate framework. Very importantly, that our high-stakes decisions are made in a credible and transparent manner, that we're using a holistic approach. And very importantly as well, is that we seek to gradually increase the learner's agency and accountability for their own learning, through the learning being tailored to support the individual learning priorities. So what does this look like for us? So we took what we knew is necessary to start with. We knew that we needed a portfolio of evidence. We needed some sort of evidence of the rotations that the registrars completed during their 4-year program. We have currently mid-block and end-of-block assessments. We want to introduce, although we do have not formally, work-based assessments in their multiple forms. And all of these different assessment points then go into a review by a progress committee biannually. And these then receive a cumulative global rating, which would, for the moment, the plan is to make that 10% of the final mark. We realized there was a need for a national standardized exam. Some specialties take advantage of an intermediate exam. We realized that will probably not be feasible in our context for our college. And so what we propose to do is to develop an exam which is also attended by external examiners from the other universities. And we run this exam on an annual basis. Each registrar would have at least 3 opportunities to sit this exam, and that we have a weighted average, which counts 10% of our final mark. All of these, in addition to the Part 1 credentialing, the portfolio of evidence, as well as the 3 exams, will permit the registrar to enter the exit exam, which is the FCAM Part 2. And for the moment, for the foreseeable future, that exam will still count largely 80% until we are certain that we've got really rigorous assessment processes, as well as the technology to back it up, and the buy-in from our end users, both our faculty and our registrars, before we adjust that weighting any further. And so from this point, we attempted to put through an assessment blueprint, and these numbers of assessments and units of professional practice, which we'll come into now, is what we perceive to be feasible for the different faculty in the workplace. This is just a draft and still needs to go into a second process to reach consensus. From this point on, we understood that we need to have a common language that we speak of when we talk about what is competence. And we realized that we need to understand how competent our registrars are in terms of how they're able to work. And so this concept might be familiar to some of you, entrustable professional activities. And what this allows us to do is to measure that competence, but relate it to discrete professional tasks that may be entrusted to a learner to be executed unsupervised once he or she has demonstrated the required competence. So herein we see a shift from individual competencies to work that must be done. And so what this does is move away from person descriptors to work descriptors. And so if I have a conversation with my clinicians on the ground as to, what the health system knowledge the registrar possess, what's that like, I think there'll be more meaning. We think there'll be more meaning if we discuss the design of the treatment plan. Or is a registrar able to resuscitate a patient? Are they able to counsel a patient? Are they able to lead a family meeting, as an example? And so the language of how we address competence changes. And what we're trying to do is to gauge the level at which a registrar reaches proficiency. This is the point at which they are ready for unsupervised practice. And we accept that after graduation, that there's still a process of learning. And this occurs through deliberate professional practice as a postgrad. And so what does the EPA model look like? Well, essentially, the EPAs, or units of work, are very discrete bundles, such as resuscitate a patient, which we might introduce from year 1, 2, 3, or 4. And there are multiple opportunities across the 4-year program for different assessors to determine whether a registrar is ready to, or is competent, rather, to resuscitate a patient. And so what we are actually looking for is a point at which we're able to act unsupervised as well as supervisor junior. We accept that the EPA model is very much a global north construct. And so it was quite interesting when we started the process of curricular renewal. Initially, it didn't seem like this was the right fit for us. How do we manage the EPAs? How do we map this, both technologically, and also how do we make this feasible for our faculty who are meant to assess our registrars? And this was an interesting process because we went from maybe we'll use EPAs to maybe actually we need to find a different way to bundle a group of work-based assessments and to make that meaningful in the construct of a single unit function. Because we struggled with the idea of what does entrustment mean for South Africans. Our undergraduate, our community service doctors often work with distant supervision. Our registrars, very often on day 1, are expected to act unsupervised. And so, whereas we accepted that perhaps we need to look at our entrustment levels, that the idea of units of professional practice actually did work. And so we thought to take it in meaningful chunks and to identify 11 core functions that would be expected of a registrar if they are in an emergency centre. What is it they're able to do from the get-go? And clearly, they must be able to resuscitate a pulseless patient. They must manage critically ill patients. And the reality is that the majority of patients that we see in emergency centres are non-urgent patients. And these can be anything between 40 to 60% of the patients that we see. Palliative care patients are a large number of patients that we see, and therefore they must be able to both create and implement an integrated management plan. Our burden of acute mental health care patients is quite high, and therefore that features on our list. Leading a handover round, absolutely integral. And then the disposition of the critically ill patient for transfer. And this speaks to our different tiers of health, different levels of healthcare in our context, and the need to transfer our patients from one unit to the next. Similarly is the transition of care. And that's not just creating a disposition plan and discharge for our patients, but it's linking to community-based services. It's that continuity of care. How do we link to different tiers of healthcare? Very important for us was recognizing and managing the vulnerable patients, as well as managing a patient-related complaint. Unfortunately, a daily function. But also we realized how important it is for a registrar to be able to teach a small group of juniors and provide feedback, and similarly be able to learn and accept feedback. And so the idea then is to be able to create, at the end of our assessments, looking at these units of professional practice, areas for development for our registrars. And I think presenting it this way would make something far more transparent in terms of where the deficits lie. And from here on, we are able to create a progress plan for the individual registrars in discussion with faculty and a progress committee. And so this progress committee is really important. So instead of having a one assessor or two assessors, or even worse, having a group of assessors at the very end of your training program, we now recognize the need to have different opportunities to assess progress, to identify very early on the registrar who might be struggling, the registrar who's not fulfilling the programmatic goals. And so our challenge then from this was, what are the tools that we need to use? And so there is a very strong focus on technology, and the College of Medicine South Africa has a working group themselves who's looking at different methods which we could employ. We as EMCT, that is Stellenbosch and UCT, will be or have been utilizing REDCap, and as the curriculum working group will utilize REDCap in the interim to identify exactly what our requirements are as a specialty, and then take that forward in terms of our entrustment scales and how that links to the electronic portfolio, whether that is logbox or whether that changes in time. And so that all of these can be linked and made accessible to the progress committee seamlessly. And very importantly, not just with the progress committee, but one that is available to the registrars on demand. And so our timeline then, I think we're rather realistic in that we realize that the year 2023 will probably have a draft in June this year. And therefore the website on the College of Emergency Medicine will change to reflect those changes, but that we cannot actually initiate any effect on assessment. And that will probably only come in through a process of iterations and piloting with both our faculty in the workplace as well as the working group. And so we don't see our assessments weighted any differently for the next few years to come. But I think we will strive to pilot our work-based assessments. We'll also pilot the e-portfolios for incoming registrars as of 2024. And of next year, June, that's June 2024, form our first progress committee meeting, and probably before that trial, our annual performance exam. And so a lot of this discussion has been on curriculum renewal. So exactly where does the transformation come in? And so I think that's really important because through the many conversations that we've already had and those still to come, the faculty development, not just in the curriculum working group, but as we proceed to develop faculty in terms of educational principles and leadership, as we engage with different partners or stakeholders, as we engage with community, all of these engagements together with the students in trying to identify what our students learn, how, where, who facilitates their learning, and also why, I think will eventually emerge in that process of transformation in terms of developing an inclusive, responsive, and future-focused, socially accountable curriculum. We hope to have competent facilitators of learning and educational leaders, and that we will also develop, very importantly, competent, socially accountable graduates and change agents who serve our community and our population, and develop a curriculum that we are proud of as South Africans and Africans. And so we are cognizant of the various limitations, and one, that we have the sheer will to engage with community. What that community engagement is going to look like, we must still decide as a group, and those engagements must still be had. Do we speak to our lower acuity patients? Do we go out into the communities and to have for us to understand what their expectations of the emergency physician is? What experiences do they expect when they come into the emergency centre? And then, of course, is the technology. We appreciate that there are many different generations of specialists who have to engage with technology. That paper-based has been something we've been working with for many decades. And so now to transition into technology, which is favored by our registrars, what does that look like? How is it seamless? How do we take on the various WBAs and assessment points from our EPAs? And how does that feed into a central point that we can actually refer to seamlessly, that will be accessible to both progress committee, to registrar, and to college? And then, is it actually feasible? And this is really important for us. We understand that our joint staff are overburdened. We understand that we are resource constrained. We understand that our registrars are overburdened, have a service delivery imperative. It's part of their job description. And so how do we make it feasible for them in terms of what our expectations are? This has to go in different iterations in terms of the numbers, the type, the EPAs that we can actually utilize and bring about that will not significantly impact the work or the service delivery, which is expected and which is a non-negotiable. Furthermore, is it feasible? Can this be applied to our specialist blocks? For almost 2 years of the registrar training, our registrars undergo a specialty block with anesthetics, ICU, obstetrics, gynae, pediatrics, pre-hospital, trauma as well. And so are our partners able to utilize the same assessments? Are they able to provide us with mid-block assessments, end-of-block assessments, work-based assessments? So these are all still questions which we need to answer. And I think this is going to go into a cyclical process of asking, of inquiring, and then renewing our curricula. I'd like to think that that process of inclusion is really important, and we accept that it's change is disturbing when it is done to us, but exciting when it is done by us. And therefore, as we go through the next few months, you will find us engaging with most of you on this call and more, faculty on the ground, both emergency medicine, family medicine, and the other specialists and professionals that we engage with on a day-to-day basis in the workplace, to be able to streamline and to come with a curriculum that's actually feasible, that's workable, that we can implement. And that brings me to the end of that overview. This is a photograph of the curriculum working group taken at the end of January. A nice bunch, I have to say, and includes our registrar representatives. A few references if you would like, and I'm happy to take any questions. Thanks for your attention.
Thank you very much for your presentation, Waseela. It's Colleen Saunders speaking. Clint just asked me to handle the questions for Waseela. He's struggling with connectivity. Thank you. I really enjoyed having had some exposure to you as as you'd gone through the process. I really enjoyed learning about the details. Thank you for that. Are there any questions? I can't see. There's nothing in the chat. If there is anyone who has a question, perhaps just raise your hand. Oh, there, sorry. Peter, you are up first, and then I'll go. Steve, as soon as you've unmuted, you go first, and then I'll jump to Peter.
Oh, okay. Have I? Can't remember what I've done. Waseela, thanks for excellent presentation. That was really, really good. I was really interested in the history of the evolution, which parallels family medicine as well. My question is about community engagement, and to what extent that could be seen as an entrustable professional activity. In other words, the extent to which graduates can demonstrate that they understand a systems view of the things beyond the emergency center. Because I kind of feel that sometimes lacking. You deal with the next patient, and maybe a bunch of students. I saw that in your list, but I didn't see maybe it's somewhere else, but the ability to look at a situation, at a pattern that's emerging, at a broader view rather than just what comes through the door of the emergency center, in order to be able to anticipate it and design appropriate interventions that work to a certain extent upstream and collaborate with other members of the team. So that kind of whole shift and the incorporation of emergency medicine into FACE is really what I'm hoping we would be able to facilitate over the next few years. Yeah.
Thanks for the question, Steve. I think it's a really important one. And perhaps it actually forms quite a large part of the discussion of the working group when we did sit down for the workshop. And we were very intentional about just that. And that theme of community, social accountability, and a team-based practice and context-specific practice came through quite strongly. And it was from there that those competency domains emerged. And it is within this construct or the description of those competency domains, I think that will become more transparent once those are transcribed. And what it does include then is the need for engaging with different levels of care. It is encompassed in the EPA, which refers to the transition in the levels of care. And of course, we had to make these very discrete units because they had to be ones that had a defining endpoint. And so we had to create sort of units of work that would make sense for the individual patients. But it is actually incorporated within that particular EPA. And also then in terms of team-based practice. So the team doesn't just speak about the team within the context of the emergency center, but the bigger team with the bigger community of practice, be that in the linkages to different tiers of healthcare or different professions, and most definitely considers community engagement. What that looks like, though, and I think before we can probably assess it, is what are the opportunities that we have in the curriculum to teach it and to role model it, is what we need to be very clear about. And I think that's probably where we'll have opportunities to engage with yourselves in family medicine to create those opportunities for learning, because the assumption is made at the moment that our registrars understand the system, that they understand the context in which they work. And we do realize that is probably a deficit or a missing piece, because we don't actually take them out into those communities to have that understanding. Currently, it's an assumption. So yes, there's work in that regard, but we realize that it is a priority for us, and therefore it's actually part of our battery.
Thanks, Waseela.
Thank you, Steve. Peter?
Thanks, Waseela. That was great. It's given me lots of understanding of what you're doing, and it looks great. My question, and you may have answered and I may have missed it, but how transferable is this to the other specialities? Have they done it already? Have you copied from them, or is this our process that you've done from scratch? And yeah, I'm interested to hear from Klaus and Renee and Jeroen how this will work for them.
Yeah, very good question. Thanks, Peter. And so we started out looking at what the other specialties are doing. And I know anesthetics has done quite a bit of work. They've developed their own competency framework. I know ENT, obstetrics and gynae has done quite a bit of work on EPAs. I know the surgeons are currently working on the EPA model as well. And everybody has been mandated to look at work-based assessments as well as introducing EPAs into their specialties. How it links to the other specialties, I can't exactly answer for Jeroen and Klaus, and perhaps they can be part of the discussion. But I think certainly that there must be overlap, and I think I personally see opportunities for collaboration in different aspects of our curriculum, especially as we've already mentioned in terms of our community engagements. So I'd welcome, comments from Jeroen and Klaus, and or even Taslim if you're on the group. How much does this differ from what you're currently doing? Would love to hear. Sorry for putting you on the spot. But yes, Peter, I think from an emergency medicine perspective, we're starting from the ground up, and I think we need to. I think the assumption so far has been that the adapted IFM curriculum will work long term, and I think we've realised that this needs to be a pure African construct, that it needs to work for our context, and so therefore the need to actually construct competency domains. What we are currently working on is the core competencies, which will give a better description of what those domains are, and give more meaning to or answer some of the questions yourself and Steve have as well.
Thanks, Waseela. I see Klaus has raised his hand. Klaus, you're welcome to respond to Waseela's challenge.
No, I don't see it as a challenge at all. And I see Steve has also replied in the chat, and I was actually holding off to wait for Taslim to step in because I think he's been also quite involved with the national workplace-based assessment activities, which has I mean it was a great question also, Peter, because there is nationally quite a process going through the colleges of medicine across all specialty disciplines, and like Steve has said, that Louis Jenkins is our, in a way, our guru and lead. He has worked also with Olet and Carter about EPAs, and we were looking at workplace assessment, and really also looking at different models of the electronic portfolio at the moment. But it was really fascinating also to see the similarities and the overlaps, especially finding that disciplinary identity. And I was also tracking in my mind the disciplinary timeline that you have also so beautifully displayed, and how that also correlates very much with the history of family medicine in South Africa. And I think we are definitely have lots of overlap, and we are definitely in the same place in this space in history where we find ourselves of grappling with the similar conceptual challenges about where we wish our graduates to what is the ideal graduate would look like in terms of competency and outcomes, and I think also mapping out also the detail of the process, and as well as keeping our workplace-based assessment colleagues and especially joint staff also on board is crucial in this process. So it needs to be an inclusive process, and I think it's really an opportunity to be very transformative in how we think and co-create and co-develop what is needed within our different communities of practice. So I'm very excited about the work that you're doing, Waseela, and I think that we definitely need to have more conversations such as these. But I welcome also, maybe I think there are other colleagues on the call who might also have ideas about how things are doing. But essentially, Peter, your question was spot on. Thanks.
Thanks, Klaus. Yes, quite a bit of work that's underway at the moment with the college. So we've got different working groups, EPA technology, as well as looking at doing a situational analysis. And so there will be an EPA workshop in April at UCT, which a few of us will be a part of, just going through more an information session than anything else in as to what is an EPA, how to construct it, and just starting from the ground up. So there's quite a bit of college support, which is amazing. And so I think the background work will go on, is gaining momentum. There is the concern about how feasible all of this is. And so that's the back of our minds. And so very importantly, like I've said over and over, we need to work closely with our joint staff and to make certain that this is actually feasible in the long term and that it's sustainable. Yeah, so thanks for that input, Klaus.
Thanks, Waseela. We do have a few minutes left if there are any more questions. I'll give it the obligatory couple of minutes. Yes, was that Steve?
Again, at the risk of boring you, I shared a different iceberg diagram with Clint the other day, which is this one. I don't know if it's coming through.
It is, we can see it.
Okay, so what seems to me is that most of us as clinicians deal with patients as events and we react to them. And after you've been in the game for a while, you start to see patterns and you can anticipate them. And what we need to be delving into are the structures in order to be able to design our systems more adaptively. And even at the deepest level there, the mental models that Shahid actually presented this the other day. The mental models that drive in other words, the assumptions that drive the structures, that keep the structures going, that produce such a lot of whatever it is, trauma and distress that end up in emergency centers. And I really think as a department, we need to be using this kind of a lens to have a generic approach to health systems, the kind of health systems for clinicians.
That's interesting. Thank you, Steve. Looks like a point that we can definitely engage on. Sorry, did I cut off or was there?
No, I got.
No, we got you.
Sorry. Yeah, I think we make a lot of assumptions, is what I was saying before I got dropped. Anyway, enough of that.
Okay, then I think that doesn't seem to be any other. And oh, sorry, Roger. Last one, Roger.
Thanks, thanks, Colleen, and thank you, Waseela. I think a great presentation of the overview. I have one query. When we look at what we want an emergency physician to do, it tends to be a bit philosophical. And often the realities of what we are expecting our new graduates to do is somewhat divergent. there's very little focus on staff management, HR, equipment monitoring, that kind of thing. Has that been included in the curricula? And then I'm very pleased to see the inclusion of the DOH, particularly in EM, because I think one of the greatest difficulties we have is that nationwide we're graduating 20 or 30 emergency physicians a year, and the majority of them are not going into emergency medicine work. And has there been any engagement from a college perspective in that regard?
Thanks very much, Roger, for the question. And you actually raise a very good point. And what we found quite fascinating in the engagements with the different partners or stakeholders was the need to include just that. That is aspects of management. Our graduates, our registrars realize that very little of what they do when they emerge as consultants functioning in an emergency center revolves around pure clinical function, that what they need to be actually educated on are concepts of both management and leadership. And so we've taken that on board. And actually, when we did the weighting, the need for teaching or inclusion of management principles was a module has actually weighed quite heavily. So you're absolutely 100% spot on. I think that's reflected across the board and definitely will be included. And therefore the domains of manager and leader featured so strongly. But also I think it perhaps appears more philosophical when it is embraced within a framework of competency domains. And perhaps it will become far more transparent once we start describing what those competency domains mean, what the core competencies actually are, because then what we've got are measurable knowledge, skills, attributes. And from we can then construct different modules or different opportunities for teaching, learning that will encompass the different aspects which have emerged, but certainly management, leadership, and then a lot of a sense of identity, like I've already mentioned, and well-being. Hence the need to be encompassed within this sort of a veil or idea of self-care, of development. Yeah, so thanks very much. In terms of the DOH, I'm sorry, I don't think I quite understood your question there. But yes, intentional about including all members in the Department of Health. We've had more engagements, I think, from the other universities than we have had in the Western Cape in that regard. And I think because we appreciate that we're going to have multiple opportunities through the next 2 or 3 years to actually engage. But they are an integral stakeholder. But absolutely, that's going to continue. Many more conversations to come. Thanks, Roger.
Thanks, Waseela. Right, so we are spot on 2 o'clock. And so I think we're going to end the seminar there with thanks to Waseela for a great presentation, stimulating lots of discussion and thought around how this can be translated into the other disciplines as well. And I see that there's a few things being plugged in the chat as well, so have a look at those. Klaus has just posted a few items there. Thank you, everybody, for your time, and I'm sure Waseela is open to some emails or follow through as well. Thank you.
Thanks so much. Thanks, Colleen. Thank you all. Bye-bye.